Now we are moving on to next topic. The topic is failed fundoplication, evaluation and decision making. Now I invite Dr. Dipankar Mukherjee to come over the dais and go over this. Dr. Dipankar, please go ahead with that topic.
Do I control it myself? It's not projecting. So thank you, everybody. Before I start, I want to say three things. Number one, my father's friend, Dr. Alok Banerjee is here. I don't have my father anymore. In Sanskrit, we say, Pitari Pritamapanne Priyante Sarvadevata. So I'm really honored to have my uncle over in the audience. I'm really honored by that. The second thing, I cannot thank the organizers enough. I go to a lot of conferences, it comes with the territory, and I must admit that this is one of the most inspirational, one of the most well-organized meetings that I have been to. One of the organizers coming through, Dr. Debakshi, and I can't thank you enough. The third one is a special congratulations to the organizing faculty. It is not possible to attend every session in this event where a lot of parallel sessions are going on. But I'll try to attend, and I'll request everybody to attend a session tomorrow, which is called Women in Surgery. When I went to UK about 30 years ago, the hall looked exactly like this, filled with men with one or two women in the corner. Right now, I have got three senior residents with me, they're all women. And there is something we're missing the trick. We are actually losing 50% of the talent in our population. They're being taken away by the gynecologists. So for the leaders amongst you, my appeal is that women should not adapt to surgery. The surgery has to adapt to women. It is very flattering to talk about failed fundoplication. Thank you, Sanjay. Obviously, my poor reputation has reached Calcutta. But on a sort of more serious note, your results and our results are inversely proportional to the length, quality, and rigor of our follow-up. So that is why young are feisty, because they have not yet been humbled by life. As you do this more and more, you will see the failures. The principles of this sort of situation is exactly the same. Never do the harm, or I try to minimize the harm. And if you do harm, at least accept it and treat it, and if you can't, send it to somebody else who can. The third point has already been done by Dr. Mohan at length. That was the topic of his lecture, that only operate if it is absolutely necessary and you can predict success. This is a strange surgery where you have to actually be able to say that this operation is going to work. I was tempted to put the YouTube video, but I didn't because for the sake of time. I'm a Star Wars fan, and in the episode 7, Yoda says this to Luke Skywalker, who has failed. He is the failed Jedi, and Jedi has come to an end. And then Rey comes to, the girl, the first girl Jedi, comes to Luke Skywalker to learn about Jedi religion and Jedi training. And he says, I can't do this because I have failed. And then Yoda appears as a spirit and says, pass on what you have learned, strength, mastery, but weakness, folly, and failure also. Yes, failure of all, most of all, is the greatest teacher failure is. And it is something that all surgeons should remember. And I'm very pleased to see there is a lot of talk about complications and problems. I'm going to skip the rest because this is something has already been covered. What is the problem of GERD? It's a strange disease. It's multifactorial etiology, complex pathology. There is no obvious anatomical surrogate. You may not have an anatomy to fix in the first patient. Symptoms do not always predict the diagnosis, but without the symptom correlation, you cannot operate. pH-metry has its problems, although it is mandatory, and endoscopy can be often negative. Never sell this operation, certainly in the West, there is a lot of Barrett's. Never sell this as a vaccine to esophageal adenocarcinoma because it doesn't do that, and it doesn't cause Barrett's regression. And there is no perfect anti-reflux surgery, so it is very, very important that you talk about the imperfections, even in an ideal patient who's going to have this operation. I'm going to talk a little bit about what failure means, and then how we can prevent failure, how we can detect failure, how we can treat failure, and then hopefully if you've got time, we'll do a bit more. So the failure, what we call, can be three types. You did an operation that did not work. That means your selection was wrong, not necessarily did a bad operation. you cause new problems. Now, in the short term, that is invariable. Every patient who has a fundoplication of some sort is going to have dysphagia, is going to have gas bloats, is going to have flatulence. That's going to happen. But they will regress over time, but the acid control should remain well, and the original symptoms should go away right in the beginning of the procedure. So these patients should come out, and I see them in the recovery, and they will say, my reflux is gone. And you know that it has worked. And if it hasn't, then you've got a big problem there and then. And then you have got recurrence or a late problem, which is also a failure, which is majority, where the old problem has come back, or the problem that you caused in the short term hasn't quite gone away. I mean, they have got persistent dysphagia, etc. So, failed fundoplication strategy is exactly the same as the primary surgery. So you assess and treat. However, remember, you can prevent this, and that's what the talk was about in my previous colleague. Select well. Reflux never kills, but no anti-reflux surgery is perfect. So humility is very important, I think. It is very effective in treating reflux, but gives rise to new symptoms. And the third one, which I put in bold, is that this is where we surgeons don't always do it well, and we can get away with it, with imaging, etc. But in this part of surgery, which is functional surgery, mostly, because with double dose PPI, most of the even the grade D esophagitis is going to get better, and you can dilate them. You are treating symptoms. So if the patient doesn't have symptoms, if you have not understood their symptoms, and if they have not been then assessed and correlated with the objective assessment, then it's going to fail. Setting expectation is very, very important, because these patients will have new symptoms. Do not sell the operation. And as I said, this was the sort of topic. So the best patients which I will talk about is basically patients who are regurgitating a lot, they can't sleep well, etc. But they have to pass what I call Agni Pariksha. Yeah? So they have to pass that. They have to pass the test of pH metry, and I'm very glad to hear that Indian guideline has included that. This is the bare minimum, in spite of its problems. Ideal candidate of anti-reflux surgery does not look like me. They are slim. They have some response to PPI. If they have not responded to PPI, be very careful that you're probably treating functional heartburn. The symptoms are predominantly esophageal. Don't operate on patients who are cough predominant, or they have got asthma, etc. They may get better, but they may not. So if the patients who are getting, especially, they lie down in the night, they get a lot of fluid coming out, they have a choking episode, they sit up, and they're frightened, and they cannot go back to sleep. And this happens night after night after night. They cannot sleep, which means that it affects their life quite a lot. And what happens that the family thinks that they're hypochondriac because there is no visible abnormality outside. And in fact, they start thinking about that themselves. Ideal patient has a small hiatus hernia, a low basal sphincter tone, pathological supine reflux, although we operate on bipositional reflux and objective score. If you have got a large hiatus hernia, you can operate, and that's the indication is different. And these are some of my patients that I operated on. You can see these patients are actually quite easy, because what you're trying to do is to prevent gastric strangulation, and their symptom is terrible pain. They can't eat, and they can't eat not because they're dysphagic necessarily, but because they get terrible chest pain, they get pain going to the shoulder, and they're frightened, like they think that I'm going to die, yeah? Something that happens with massive visceral pain like a heart attack. So this is a patient I tried not to operate in 2013 because the stomach was in the chest, it was filled with air, and in nasogastric decompression the patient did well. She didn't want an operation, I was not particularly keen on it either. She comes back in 2015, and this is only one of my patients who was anesthetized sitting up. And I have somebody who is extremely expert anesthetist, and he managed to do that. And we operate on him, and look, 7 years down the line, the patient remains recurrence-free, and in fact she has developed gallstones now that I'm going to operate on. So, what I can do in the first operation to prevent problems? Dissect, dissect, dissect. And when you dissect, dissect adequately. And if you think that you have dissected enough, dissect a bit more. Have at least 6 to 7 centimeters of intra-abdominal esophagus in the abdomen. And remember, if you've got a tape and you're pulling it down, it's very easy to make that 6 centimeters by wishful thinking. You've got pneumoperitoneum. These are all laparoscopic operations. So the caving up of the diaphragm caused by the pneumoperitoneum may make you feel that you have done enough and the esophagus is down. It may not be. Preserve vagus. You have to preserve vagus in every one of these patients. And remember, it is an esophageal wrap and not a gastric wrap. Now we have gone to robotic repair. The technique is slightly different. However, the principles are exactly the same. This is a patient that I did, I think, only a month ago, or in fact less than that. And it has got its own problems. It has got its own tricks. If you have got a fixed retraction system on arm 4, and you're pulling at something, you basically have two things that you're going to just tear things. So you have to be very, very careful because there is no haptic feedback. But that's the topic of another talk. When things go wrong, because they will sometimes, sometimes things will not go well. And the important thing is that when you have this sort of failure, it has an emotional impact on you. Talk to a friend. You will suffer along with the patient. But the important thing is that do not abandon this patient unless you think you cannot do it. So that sometimes you may not be able to do this operation. You can send it to somebody else, talk to them, call them, remain their advocate. You will support them, you'll be supported yourself, and you'll probably avoid some medical legal issues as well. So these are the assessments. We talked about it. This is after surgery when things have gone wrong. The first thing we do is that we think that it's our problem, and that's how surgeons are made. It can be an esophageal outlet obstruction, and the big question is, do we have to operate? My manuscript that is getting ready, we have got 330 patients, and we've got 16 reoperations. In fact, and there is 2 more waiting, so that'll make it 18. Does that mean that my failure rate is only 6 to 7%? No, it's not. It's more than that. And if you include the giant hiatal hernias, you will find the World Series, they will have anything between 20 to 40% of radiological recurrence. Do not treat the scan. Do not treat the X-ray. That's something has been mentioned by, I think, Dr. Dama yesterday, and I agree with that. Remember, we are builders. We fix anatomy. We make things. We work with our hands. The surgery, word surgery comes from 2 words, which is kiros and ergos. Kiros means hand, ergos means work. We are manual workers. So unless you have got an anatomical problem, you cannot really fix it. So remember that you have to assess that. And what we can do at operation. Can we do something different? Sometimes you can just do the previous one better. Sometimes you have to do other things which include mesh, which may include gastroplasty, which may include diaphragmatic release, etc. So these are the problems that you can have. You can either have a very tight wrap, which is causing esophageal outlet obstruction, very fashionably called OOO. You can have a disruption of the wrap, or you can have a malposition of wrap, which can be either telescoping, or it can be, this is the telescoping, which is a classic slip Nissen, or the whole thing can go up to the chest. In my view, the patients that you're going to operate on will almost always be either 1, 2, and 4. You'll almost never find a pure 3, because if you did that, then you probably didn't do the operation well. So this is a patient I'm just going to tell you about. There was no problem with the, I think there's a video here. So there was no problem to start with, and then she comes back. This is one of my trainees' operation, but I supervised, so I took the full blame for it. She had a very, very good symptom relief. Classic Nissen fundoplication. In about a year and 3 months later, she remains very, very satisfied. And then, between June and October, she just gets worse very, very rapidly. And you find this. You find this wrap that has telescoped and gone into intrathoracic migration. If the patient is well, you can still leave them, however terrible it looks, except that she wasn't. So she had very, very severe reflux, this time upright and supine position. Look at the acid exposure time. It's just gone through the roof and has perfect symptom correlation. So this is certainly not in patient's mind. And this is what the endoscopy showed. So I'm going to, as I show the video a little bit, and I will just go through it. So you can see that there is a widely gaping hiatus. This has happened because the anterior repair has just dilated. And this is obviously after reduction. So you can have about 1/3 of the stomach going up. And this is something that has been well recognized and well described. Somebody in, I forget the surname, Sumit in America, what he'll do an anterior repair. A lot of Australians do that. It's not normal practice. Remember, the dissection is quite difficult in this situation because you're going into scar tissue and you have to do it. So you can see no esophagus here at all. And you have to start like a normal hiatus hernia dissection where you go to the hiatal arch, you dissect the hiatal arch rapidly, and I'm trying to speed it up actually if I can. And then you can also, once you have done that, you have now dissected the hiatal side and you have to dissect on both sides, and slowly the esophagus will appear. The esophagus still has not appeared, and now I'm dissecting in the left crus area, going into the mediastinum. And essentially the idea is normalizing the anatomy completely. So you can see those crural fibers, which are normally, they continue with the esophagus, as you know, they become scarred, and they become, this is not easy surgery, because unless you do a lot of hiatal surgery regularly, one should not do this. And the most important principle here is actually make it completely bloodless. If you are not bloodless, and these energy sources help a lot, if it is not completely bloodless, then it will go wrong. I'll try to speed it up for the sake of time. Can you put it on fast forward, perhaps? I can't do it here. So you can see that now what we are trying to, you can see some sort of green fibers, which are basically the previous stage. This is the retroesophageal area, that is the retroesophageal area being dissected, and now with these crural fibers, which are often attenuated, and you may have to divide some of them to actually get into the mediastinal plane. The mediastinal plane is usually not a problem, because the scarring is usually not that bad. The scarring usually is limited to the hiatus, but you have to mobilize the esophagus a lot, and once you have done the mobilization, you have to keep on mobilizing till you have defined the anatomy completely. And the important thing is that a lot of reoperative surgery, you see, is full with blood. There cannot be any blood. If there is any blood, you have to stop the bleeding, and then carry on operating, which is what is being done. And now you can see the intraabdominal esophagus has appeared. The esophagus is going to come down. But even at this stage, if I just let it go, it will just go up. And now you have you get the idea. So you see that's where you'll see that the hiatal failure has occurred. So what has happened, on the back, there is no space. What has happened, the hiatus itself has dilated anteriorly, as you saw right at the beginning of the procedure. And once you've identified the previous repair, then obviously life gets easier. For the sake of time, I'm going to stop the video. So what I did here is, time's up already. So I'll probably stop, sorry. So these are some of the patients that we did where and occasionally you have to put a drain. This is another patient who has transhiatal lap herniation. Consider whether they have got a short esophagus, consider whether you need to do any other procedure, etc. So because of the time, I'm not going to go through all this. I'll just show you this one. So how do you put a mesh? A mesh is a very controversial topic. And I think yesterday morning when we were talking, Inian and I and a few other people, we all agreed that we are going to use a dual mesh, which is PTFE coated. Only one side is coated. So remember, you have to put that coated side on the below. And the other thing, the big word of caution there, that do not put a bridging mesh. So you've got a big hiatus, and you may think that I'm just going to cover it with a mesh over the V. It will fail. So what you have to do is to stitch it together, and if there is a tension, then do a diaphragmatic release on the right crural side. You'll produce a capnothorax. It's of no consequence. You don't have to drain it at that time. All you do is to keep on operating. The anesthetist is going to give a positive pressure ventilation, and it'll be okay. When you put the mesh is horseshoe shaped, and it's PTFE coated. You fix it to the right crust. You fix it behind the esophagus to the left crust, but keep the anterior side intact. The only time I had a problem with the mesh is because I made some mistake, which I encircled. That was the 4th time recurrence that was referred to me. I operated on the first time, and I was tempted to encircle the esophagus. 2 years down the line, the patient has absolute dysphagia, erosion, and I ended up resecting. And lo and behold, after the resection, the patient was completely symptom-free. And he was very forgiving, but I was falling apart. So this is the overlay dual mesh that I talked about, and then you do a 360-degree wrap. In terms of success stories, what is the success rate? This has been shown in the literature. The success rate is actually very high. But the success rate is not dependent on the quality of your surgery. The success rate is related to your understanding of the patient and your assessment of the patient and your selection of the patient. Thank you.
Hello.
Can I just do this one, if I may? These are the take-home messages, which is worth doing, actually. Remember, we surgeons can only correct anatomy. That's number one. Identify anatomy before surgery, and you will find that you'll often get it wrong. When you think that there is no slip wrap, etc., you'll find a slip, etc. That's okay, but remember that. You don't have to operate. You can leave these patients if they're symptomatically well. So there are situations where the surgeon suffers, the patient is fine. In that situation, don't treat yourself, treat the patient, and don't treat the scan either. And then decide, and at the bloodless dissection is very important. Decide what to do, but also very importantly, what you do not do. That is very, very important. So select carefully, Think twice before operating. Assess failure care early. Think 10 times before reoperating. Identify anatomy. Spend time for consenting. Sense check success and take second opinion from a benign MDT. One of the son of the soil, I don't know whether any of you know him, Sayan Bhattacharya in UK has just set up the National Hiatal Registry where people can go and look up their own results. So he has done this so that they get engagement, so that people are not threatened their results are up in the, although I think it should be more open than that. And is there a short esophagus? And do you need to do something else on top of what you've done the first time? Thank you.
Thank you very much, Dr. Dipankar, for your nice presentation. Now the topic is open for discussion.
Thank you.
Enjoyed your talk, Professor Mukherjee. My question is related to your the type of wrap that you do after failed fundoplication. Is it possible to do a Nissen? Because there are surgeons who believe that because of the scarring, you may not be able to do a tension-free 360-degree, and it may be wiser to do a partial fundoplication. Now, especially since it has been shown conclusively that partial fundoplications are equivalent at controlling reflux with the 360-degree Nissens. What is your opinion on that?
So I'll take the sort of question in two stages. Number one, is it equivalent? Of course they are. That has been shown by Watson's. There are many meta-analyses who show the similar thing. But in these patients who have got a hiatal failure, you are better off doing a 360-degree wrap. I have a patient where I use Watson's wrap, but I use it very selectively. So I've got a patient who had Raynaud's phenomena, did not quite have scleroderma, had volume reflux, and had 2 episodes of aspiration pneumonia. I did not have the courage to do a full Nissen, so I did the Watson's. And Watson's is very, very important to reconstruct the angle of His. So you sew the fundus by the side of the esophagus before you do the anterior 180-degree wrap. I think in this operation, if I could show you the whole video, you will find that it's actually not that difficult. The adhesion exists. It's what you do, right? I mean, every patient every doctor has a pet operation. If you do it a lot, you'll be okay. The stomach, the serosal side does not have any adhesions at all. They don't adhere. What adheres is where you stitched. And the trick is to actually go with either a suction catheter or a ball grasper, and you'll just lift it up. As you lift it up, I know that yesterday, I think Dr. Dama was saying that he had to, on occasion, he did not do it. In his video, that was not the case. But people have stapled. You don't need to do that. If it's like that, you better do other things. But I agree that in terms of sort of first-time control, it's probably equivalent operation. However, for hiatal failure, 360 degrees is better. So it depends on what you're doing. So I have got a patient who's one of the failed patients, one of the 2 waiting, who has got a tight wrap. Now, I don't know why it happened, because this patient I operated in 2013, come with a tight wrap. I don't know whether there's something else, but in that patient, I'll definitely not do a Nissen. I'll change it into a Watson's or a toupee. I like Watson's more than toupee. Thank you.
Yeah, thank you, Deep. That was an excellent presentation. Sorry, regarding the video that you showed, I think this was a redo without a mesh. Now my question is...
No, there was a mesh, but I did not show the whole video.
Yes.
I did put a mesh because there was hiatal failure.
My question is, suppose if it has, mesh has been put and the hernia has recurred, that becomes extremely difficult. Like, already a mesh has been put. Now this patient has got a recurrence. Now that's quite a difficult situation, a lot of adhesions. What is your advice? Well, is there any tips and tricks in such a situation where there is recurrence after a mesh being put?
Indian, I know that you are a very experienced surgeon, but actually once you have divided the adhesions, the superficial adhesions, you got the left lobe of the liver out, and you've got the hiatus identified, then usually the dissection is not, mesh is not, because you and I use dual mesh. Dual mesh only has a pseudo capsule. So it doesn't freeze in many other, it depends on biological meshes are terrible. I've never used a biological mesh, and it's one decision that I really am very glad that I didn't. So with these meshes, you don't get that much fibrosis. They're PTFE, the slip area substance known to man. That's not the problem. You can do 2 things in this situation. One is, you can dissect the whole thing like this, and then completely put the esophagus away. This is not a mesh erosion, this is a recurrence. You can put another mesh, sort of stitch the hiatus and then put a mesh posteriorly. Or the other thing you can do, which is actually not a bad idea, depending on the size of the hiatus, if you find by doing that, normally the esophagus, as we know, is not a straight vertical thing. It comes a little bit to the front. But if you keep on doing more and more posterior repair, then you actually do an anterior angulation, and the patient can have dysphagia because of that. And that is one situation where I'll probably do some anterior repair as well. Okay. But I know that some surgeons routinely, some Australians will routinely do anterior repair, and they get good result. I think it doesn't matter what you do, so long you do it safely, and so long you selected the patient well. So, and I think the whole point is that treat the patient. You have to really listen. What's his problem? Is it recurrent reflux? Is it because they've got a big hiatus hernia and they're getting chest pain? Is it because they're getting recurrent reflux, or they're getting dysphagia? They're slightly different, but that's what I do.
Yeah. Thank you.
Thank you for your talk, sir. So I have two questions. One, in the video which you showed, in such kind of a patient with dense adhesions at the hiatus, in a redo surgery, how often are you able to identify the vagus, both the trunks of the vagus, and if divided, does it have any post-operative implications in your patients, if you have noticed? And second question is, if you have a patient with symptomatic severe gastroesophageal reflux disease with abnormality on manometry detected, like a peristaltic abnormality, ineffective esophageal motility or something, what would be your approach to such a patient who is symptomatically not currently responding to PPIs?
Okay. The second question I'll take first, and about what to do with ineffective esophageal motility. You make no difference at all. And I think Dr. Mohan gave the same answer to this question, and I'm glad to hear that. Do the same thing as you do. The caveat is that do not operate on patients who don't have peristalsis. So some people only operate on the basis of Bravo. You can get a lot of reflux. It will not detect your scleroderma. It will not necessarily can differentiate between achalasia, where you have got, although achalasia is easier diagnosis comparatively, but you get lactic acid in fermented food in the esophagus, and that can give you a high pH reading. So I think the manometry is important. Not so much because your IEM is going to decide it may decide a short-term outcome, but majority of people, the days of tailored anti-reflux surgery is gone. That debate has been put in. You can do toupee, that's okay. But you don't need to do toupee because somebody has got IEM. Sorry, I forgot your second, the vagus nerve question. You're absolutely right, that's very difficult. You will not injure the anterior vagus. Our generation was brought up on vagotomy, so I think we saw more vagus nerves, isn't it, Sanjay? That we saw more vagus nerves than you guys do because nobody operates for uncomplicated peptic ulcer. So we probably know where vagus nerve is in the days of open surgery. The anterior vagus is almost impossible to injure unless you really prod into the esophagus. And you can see it very clearly like a line, and in fact in that video I saw it in the reoperative video, so that's not difficult. Posterior vagus is. So the idea is so we stay nearly close to the esophagus in the capsule between the hiatus on the right, on the arch, and the arch matters. It can be a D-shaped hiatus, it can be a U-shaped hiatus, it can be a teardrop-like hiatus. So the configuration, the morphology matters, and that you have to take into account. As you come to the back, your idea is to preserve the retroesophageal fat pad, which continues as so-called Belsey fat pad that was talked about yesterday. And I think that's where you have to stay away. And once you stay away, as you tape the esophagus with all this, then actually identifying the posterior vagus is not that difficult. But posterior vagus stays away from the esophagus, so it's very easy. If you stay close to the esophagus, you'll damage it. You can go behind the vagus then, and then there are the fibers between aorta and the posterior vagus. They're very, very easy to take. So once you enter the mediastinal plane, your life gets much easier. It's actually until that point you have to be very careful. And then you can lift the whole thing up. Does vagal denervation matters? Of course it does. That's well known. So then you'll cause another problem to the patient. But it's something that I mentioned in the principle that you have to preserve the vagus. That does not necessarily mean hand on heart that in every patient you have to identify the posterior vagus. So long you stay a lot away, you're going from the retroperitoneum, you're going where, almost near where the aorta comes into the body, and you're lifting it from there. The problem with that is that when you're using energy sources, I haven't had this complication, it's a really bad complication, is to actually have a cisterna chyli injury and get thoracic duct leak. So that's your problem. So if you do that bit you probably are better off doing blunt dissection. And the reason we use harmonic is because you can get a lot of arrhythmias. Some patients can be quite old, and if you use diathermy in that area, monopolar, you can get it. And of course, yeah, the cost is an issue, but in robotic surgery, people have gone back to diathermy.
Can I make a comment? Yeah. So I want to make a comment about this debate on partial versus 360-degree complete Nissen fundoplication, especially in the presence of ineffective esophageal motility. The first comment that I want to make is that whenever a manometry is done, there is something which is assessed, which is known as peristaltic reserve. After the standard 10 swallows of water, the gastroenterologist who does the manometry tests for a peristaltic reserve. If the peristaltic reserve is adequate, then you may be safe doing a complete Nissen fundoplication. I'm not saying that patients who have ineffective esophageal motility, Nissen is contraindicated. But now, recently we reviewed this paper and we looked at our own data and we found that patients who undergo Nissen's fundoplication have a definitely higher risk of dysphagia. And you have one patient with dysphagia and you don't want that to be repeated anytime soon. So patients who do not have a good peristaltic reserve, who are elderly, I would err on the side of partial fundoplication rather than rather than 360 degree, especially because the reflux control is equivalent. And if you look at the high volume centers, there is definitely a shift towards Toupet type of partial fundoplication.
I agree with the first point, not with the second. So I think that depends on which paper you read. I agree that the reflux control is good. I agree on occasions I have also done partial fundoplication, so I'm not somebody who rubbishes it completely. The issue there is actually slightly different. If you have got somebody who can have a lot of weight loss, yeah? So these patients are obese, quite a lot of them. They're quite happy to lose weight, so they don't mind that at all. But if you have got somebody who is really sort of very, very slim and has other comorbidities, in that situation, there is some short-term advantage. However, probably one of the reasons that I get away with it is because I get good dietetic follow-up and I get very, very good thing. Dysphagia is not the biggest persistent problem actually with Nissen. I think what the patient, because paper is one thing, and what patients tell you is slightly different, is the gas bloat. The gas bloat can be more in Nissen, there is no doubt about it. And you get gas bloat with Toupet and Watson as well, but gas bloat is one thing. I think it all depends on, surgical experiments are very difficult to formulate. You cannot have a proper control arm. You can have multi-center, but then you have to go through the surgical quality control, etc. One of the things I have changed over the years, and I don't know whether that is the reason I'm getting very good functional result, is that although I do 2 centimeter, first of all, I measure it. It is very easy to think it's 2 centimeter and it's not. So you have to measure it with a tape. And the second thing is that I don't put 3 stitches anymore. I just put 2. And I think then the next thing to do is to actually take the wrap and move up and down. And if it moves and it's completely floppy, then you know that it's safe. So I think part of it is quality as well. But I agree, with some patients, you would opt for, like this patient, the one that had Raynaud's. I did not have courage to do a Nissen because I know that over the years, as the esophagus, if it is scleroderma, if it gets worse, then they'll have a late dysphagia, which is much worse.
Can I make one more technical comment?
Last of time, please.
Okay.
Thank you.
With this, we are closing this session. Thank you all.